So it is a sharp 9 a.m. and I'm starting with a session. A very good morning and a warm welcome to all the dignitaries present here. I am Momita from Clarinet, serving as the allocated session assistant to ensure a seamless experience. Clarinet stands as India's most relied upon digital platform offering a multitude of enriching services exclusively for doctors. It is with great pride that Clarinet serves as a digital partner for this event hosted by the Indian Association of Cardiovascular Thoracic Surgeons, followed by Indian College of Anaesthesiologists, Karnataka chapter of IACTA, welcomes you to the webinar on image optimization and knobology. So before into the session, I would like to inaugurate the program with a welcome video. So I will take few moments of yours.
Good morning and welcome to the Sunday Echocardiography TE session. This is a breakfast session, and this is the fourth, actually fifth consecutive year of Sunday TE sessions we are having every Sunday. 9 to 10 is the time allocated to this session. And this, as already pointed out, is being conducted under the auspice of Indian Association of Cardiothoracic Surgeons, Indian College of Anaesthesiologists, International Society of Cardiac Ultrasound, Global Intensive Care Symposium, and Global Heart Care Foundation. I have great pleasure to invite you to this 1 hour session. And before I actually request Dr. Sushmit to take over and do the session, I request you to put all your questions and comments in the chat box. We will address them at the end of the session. The talk by Dr. Gegal Purthi, who is a leading cardiac anesthesiologist in the country. After that, we will do the question answers. And with that, I will invite Dr. Sushmit Kamat, again a star in the sky of cardiac anesthesia in the horizon of Indian scenario. So I request Dr. Sushmit to take over and do the session. Thank you so much, and I'll be back. I'll be with you till the end of the session. Thank you so much.
Yeah. Thank you very much, sir, for those kind words. Good morning, everyone. Today's topic is image optimization and knobology. It's a very important topic where we will discuss the important controls used during echocardiography. And our speaker for today is Dr. Gegal Purthi. She's an assistant professor at AIIMS Bathinda, and her areas of interest are cardiac anesthesia and transesophageal echocardiography. He has many national and international publications. So I'll hand over to Dr. Gegal for the session.
Good morning, everyone. Thank you, Moderator sir, and thank you, Dr. Sushmit Kamat. I'll start sharing. Are my slides visible?
Yes,
Yes,
ma'am.
ma'am.
Yes, and it is optimized as well. Thank you.
Thank you. So good morning, everyone. Today I'm going to talk about knobology and image optimization. So my presentation will include sound wave and its interaction with the tissues, knobology, and image optimization. So as we know that human hearing range has a frequency of over 20 hertz to 20,000 hertz, whereas ultrasound has frequency of over 20,000 hertz. So now, how the echo images or ultrasound images are formed? These echo images have piezoelectric crystals. Echo images have these piezoelectric crystals. So what do? These piezoelectric crystals convert electrical energy into mechanical energy and back mechanical energy into the electrical energy, which is known as the reverse piezoelectric effect. So when you have the ultrasound machine or the echocardiography machine, the application of the electric current to the crystal, it causes the piezoelectric crystals to vibrate and thus generate the ultrasound images, whereas the reflected sound waves hit back the crystals, and this causes the piezoelectric crystals to vibrate, and then they generate the electric current that is analyzed by the ultrasound machine to convert them into the sound waves or the ultrasound waves. So once these sound waves are produced, these ultrasound waves goes and interact with the tissues in the form of reflection, refraction, scattering, and absorption. Scattering is nothing but just when the ultrasound waves goes and hit the irregular structures like RBCs and they get scattered, whereas absorption is only in the form of heat. The main mechanism of formation of ultrasound or the echo images are because of the reflections of the transmitted ultrasound. This reflection depends on the acoustic impedance properties and angle of incidence. So when the sound waves propagates through a uniform media, they follow the straight course until they meet another structure with different acoustic impedance, and then there they can be reflected back or move in the different direction. This optimal return of the reflected ultrasound waves occurs only if the structure of interest is at perpendicular angle, that is 90 degrees. Whereas refraction, when wave passes from one medium to another, the waves do not follow the usual course and some of the waves get refracted. So you have to select the view where structure of interest lies perpendicular to the echo machine. So now coming to the attenuation. Attenuation is loss of intensity and it is due to the beam dispersion in the far field or due to the absorption in the form of heat. So as we know, there are two types of zone, that is near field and the far field. Near field is known as the Fresnel zone and far field is known as the Fraunhofer zone. Resolution is better in near field and decreases in the far field. Coming to the knobology, we know that the TE probe has a larger wheel for antiflexion and retroflexion, whereas smaller wheel for the sideways movements and the rotatory for the angle change. Different types of TE machines are available, and the knobs we should know are TE or the echo machine for the different knobs present. So first of all, you have to turn on the machine using the universal on and off button. Next is, after you have turned on the ultrasound machine or the echo machine, the next important step is you have to choose the correct probe or the transducer. Different probes or different transducers have different frequencies. So for better resolution, you need the higher frequency probes and also the larger transducer radius. So coming on to the resolution, there are two types of resolution, that is spatial resolution and the temporal resolution. Spatial resolution is ability to discriminate between two closely spaced objects. It is either axial or the lateral resolution. So axial resolution is ability to discriminate between two closely spaced objects in the y-axis, whereas lateral resolution is ability to discriminate between two closely spaced objects in the x-axis. So this axial resolution depends on the frequency. If we have seen that increased frequency will have higher axial resolution. How? As you can see in the figure B, you have increased frequency. So the wavelength is, which is inversely proportional. So wavelength will be less. So increased frequency will have shorter wavelength. So there will be more wave to tissue interaction will be there. So more data can be collected from the tissue. So therefore you will have increased frequency probes will have the higher resolution. So figure B will have higher resolution in as compared to the figure A. So next is lateral resolution. Lateral resolution, in lateral resolution, you can see, for example, in figure A, you have 10 scan lines. These are hypothetical scan lines, and figure B has 20 scan lines. So if you have increased scan lines per frame and focusing, it improves your lateral resolution. So now you have to understand what is frame and frame rate. Each image is created by a sector scan. It is known as a frame, whereas frequency at which the sector is rescanned, it is known as the frame rate. Now, what is temporal resolution? Temporal resolution is to display rapidly moving structures and distinguish closely spaced events in the time. Hence, it is closely related to the frame rate. Now, temporal and lateral resolution are not friends. As we have seen in the figure B, which has 20 scan lines, there it was having more lateral resolution. But as temporal and lateral resolution are not friends, so when you have more number of beams coming up and down, it will take longer time to finish one sector and then to start a new frame. So anything that requires more time, like the deeper sectors, the lesser is the temporal resolution. Now you have turned on the power button on, switch to the correct probe. Now each transducer will have a different list of application presets based on frequency and footprint that will automatically select the ideal frequency, depth, and gain for that application. Application preset is similar to selecting your day mode and night mode on your phone cameras. Now, after power button on, switch to the correct probe, application preset done, and you have to attach the ECG and enter the patient details so that you can save your images and the videos. You will directly have your 2D mode on after you have done all these steps, which is the mainstay of the echocardiographic examination. In 2D mode, ultrasound pulses are directed across a 30 to 90 degree of the sector of the cardiac anatomy. And this process is repeated to update the images and capture the motion. Now M mode. Coming to the M mode, M mode displays a series of collected B mode images from single scan line. And the frame rate is around more than 2000 per second. And therefore it has, because of the such higher frame rate, it has superior display of your dynamic motions and the temporal resolution. This mode is best for examining the timing of cardiac events with the ECG. Coming to the image optimization, first you should know how many cycles you should take. If there is no arrhythmia or tachycardia, if it is in sinus rhythm, a single beat acquisition is enough. Otherwise, for arrhythmias or tachycardia, at least 3 to 5 beats should be acquired. For optimization of image, you should know how to focus, what is sector size, what is Doppler optimization, depth, zoom, gain, time gain compensation, and lateral gain compensation, which we'll see one by one. In depth is simply how deep you want the ultrasound machine or the echo machine to be able to scan. Depth of penetration is also denoted in the numbers on the right side of the screen. Depth should be adjusted to include the region of interest only. Otherwise, if there is too much of depth, there is wastage of information, which decreases the temporal resolution. Next is after you have done adequate depth, if required, you can use the zoom in the region of interest. It is better for valvular morphology, pathology, and relatively small pathological masses such as vegetations. Also for the planimetry measurements, zoom is required for more accurate assessments. But there is no change in the resolution with your zoom. Zoom magnifies without change in the resolution of the selected region of interest. Now after depth and zoom, coming to the gain. Gain is actually to increase the amplitude of the electrical signal generated by the ultrasound signals. There are three types of gain: overall gain, time gain compensation, and the lateral gain compensation. Increasing overall gain of the imaging system compensates for the signal loss due to attenuation. So gain has to be adjusted such that your blood looks black, myocardium gray, and pericardium as white. If you see here, high gain, you can see lot of noise here. Whereas low gain, you cannot visualize the structures. But this is the optimum image where your blood is looking black, myocardium is gray, and pericardium is white. Gain should be set such that it should be set at minimal level and increase incrementally. Eliminating the operating room lights prevents setting high gain. And too low gain might miss some low amplitude signals such as the thrombus or some mass. In time gain compensation is called so because as the structures are deeper, it also receives back the weaker signals. So to compensate for the weaker reflected signals, we use time gain compensation. The higher settings are used for the far field structures based on the structure of interest. Mostly it is automatic automatic in some machines, this step ladder pattern. So here you can see with the step ladder pattern, far field structures are better seen. Lateral gain compensation, it selectively amplifies across the width of the image display. It may improve the view of the lateral walls. So it also helps in detection of the endocardial borders. Coming to the focus. When you are just focused, you are simply concentrating your ultrasound beams at a specific depth. For example, focus is there. So you are concentrating your ultrasound at a specific depth of the image to maximize the resolution at depth. So as we know that as the beam propagates, it will diverge and lose the lateral resolution. So that is why we should use focus at the area of interest. So because focusing further narrows the beam and therefore you will have better lateral resolution at that depth. Next is sector size. Reducing the depth or width reduces the time required for scanning and the amount of information that requires the processing, and therefore it increases the frame rate and improves the moving image quality. So after optimizing of the image, we can freeze, caliper or do the measuring of the images, and then you can save the image or the video. Coming to the spectral Doppler. Spectral Doppler is when Doppler signal is represented as velocity over time. It is known as a spectral Doppler. It can be either pulse wave Doppler or the continuous wave Doppler. In pulse wave Doppler, you have a sample volume. So it determines the velocity at a pre-specified location. There is one crystal, so it will send the pulses and also receive it back. And pulses transmitted per second are known as the pulse repetition frequency. The farther the sample volume is, the lesser the pulse repetition frequency will be there. And what is Nyquist limit? Nyquist limit is the maximum frequency limit that can be accurately interpreted. Nyquist limit is half of the pulse repetition frequency. So now what is aliasing? When aliasing occurs, you cannot determine the velocity or the direction of flow. When does aliasing occurs? When you have frequency more than the Nyquist limit. For example, here you can see the frequency is, this is hypothetical. For example, here frequency is 3 and pulse repetition frequency is 11. So your Nyquist limit will be half of the pulse repetition frequency, that is 5.5. So if your frequency is less than Nyquist limit, there will be no aliasing. But if you have a frequency, for example, here 8 and Nyquist limit is 5.5. So now frequency is more than the Nyquist limit. So aliasing will occur. And when aliasing occurs, you will not be able to know the correct velocity and direction of the flow. We can increase the Nyquist limit by either sending the decreased frequency transmitted waves or keep the sampling volume nearest to the probe or shift this baseline. In continuous wave Doppler, there is no need to wait. It means because there are two crystals and there is no limitation of pulse repetition frequency and Nyquist limit. And higher velocity flow can be determined through continuous wave Doppler. But drawback is exact location from where it is coming cannot be determined. For accurate estimation of the Doppler shift, this transducer and the direction of blood flow should be ideally be the parallel, because cos theta, the angle should be less than 20 degree for accurate estimation of the Doppler shift. And for spectral Doppler optimization, spectral Doppler should always be guided by the color Doppler. And the Doppler sample volume and line position should be, the angle of incidence should be less than 20 degrees. If you see the entrance of jet and then align, your Doppler cursor along the jet, for example, here blue line is the jet and this green is the spectral Doppler. So this angle between the jet and color Doppler should not be more than 20 degrees. Otherwise, it will underestimate the velocities. In spectral wave Doppler, this is the baseline and this is the scale. So you should remember that the spectral Doppler scale and the baseline position should be adjusted such that to show the full signal appropriately. In image 1, you can see that the jet velocity is very well represented, whereas in figure 2, the jet is very small, which can increase the margin of error during measurement. So we have to adjust the scale also, as applying a higher scale than needed will result in a Doppler signal that it's too small, and it will also increase the margin of measurement error. In color flow Doppler, since color flow Doppler is also a type of pulse waves, so there is a limitation of low temporal resolution. So the sector of color should be as less as possible, adjusted to include the region of interest. So you have to limit the color sector width to maximize the temporal resolution. So take home messages: for 2D images, you should orient the beam perpendicular and closest near field for 2D image measurements, and Doppler beam should be parallel to the blood flow. You should focus on the point of interest, decrease the depth, use zoom wherever necessary, adjust the gain, narrow the sector width, and use a focus point at the region of interest. Thank you.
Thank you, Dr. Gegal, for explaining this vast topic in a very lucid manner.
Thank you, sir.
All the important topics were covered. We started with what was ultrasound and how the piezoelectric effect works and the various interactions with the tissues of ultrasound. Then we moved on to knobology and understood all the controls and what is resolution. We discussed the various 2D modes and image optimization using the depth control, zoom, gain, which are of different types: overall, time gain compensation, lateral gain compensation, then focus, and finally coming to the Doppler controls, which involved pulse wave Doppler, continuous wave Doppler, color flow Doppler, and we also discussed aliasing. I would like to take any questions which are put. Right now, I could see that there was one question which was regarding frame and what is frame and frame rate. So, Dr. Gegal, I think you can take that question.
Yes, sir.
Yeah.
So this we can see in this image that this one frame is one sector scan. This one sector scan is known as a frame, and frame rate is frequency at which this sector is rescanned. Like for example, in 1 second, for example, if you have a camera, this camera, if it is taking that image 32 second times per second, so that is known as the frame rate. This one sector is known as a frame, whereas the frequency at which this sector is rescanned in 1 second, it is known as a frame rate. In 1 second, for example, it is normally 30 to 60 times. So that is known as the frame rate. How many times your ultrasound machine is capturing it? It is known as the frame rate.
Right, right. Very nicely done talk. Very crisp and concentrated material was presented with good illustrations. Some of the important points which I would like to reiterate that is that when you write the patient details, you must also include the ECG when you're recording or observing the echocardiographic images. It's very vital to have ECG and patient details entered. If we don't do that, it will be difficult to pinpoint the cardiac cycle in terms of the image and the exact time at which it is occurring, or the motion or the event. And patient details is again important. For example, if you want to retrieve the data, we need to go back by putting the patient details. If we don't do so, it will have a temporary ID which will not correspond to the patient's ID number in the case sheet. So you will be unable to retrieve the image effectively. The other important point which I liked was that if you want to look at the lateral wall of the left ventricle in mid-esophageal fourth chamber, you use lateral gain compensation. And also the point that spectral Doppler should be guided by color Doppler, very another nice important point which was made during the presentation. And Nyquist limit was demonstrated. And we are open to questions and comments. Any comments or questions are welcome. I think it was a crisp talk on image optimization. This is very essential to also understand how the artifacts are seen and what are the pitfalls in terms of the normal variants which can be seen. We have to know what is normal and what is abnormal. So there's one question. Can we take that, Dr. Sushmit?
Yes, sir. The question.
One more question is there. Yeah, please
Yes,
go.
yes. So the question is, how do we interpret the waveform in a pulse wave Doppler, and how to record velocity of? First, we'll answer the first question first. So, how do we interpret the waveform in pulse wave Doppler? So, Dr. Gegal, I think can put on the pulse wave Doppler slide.
Yes, sir, I'll put.
Yeah. So, you want to take the question, Dr. Gegal? How do we interpret the waveform in a pulse wave Doppler?
How do we interpret the waveform in pulse wave Doppler? So yes, for 1 minute. So we can see that spectral Doppler is velocity versus time. So here you can see this will be the maximum velocity. You can move the cursor and see what is the maximum velocity here.
Yes, and in pulse wave Doppler, since we can exactly identify from where we are getting the velocity, we can use the window to exactly pinpoint from where we want to actually get the velocity.
Yeah. You can place this sample volume at the place where you want to know what's happening at that particular point. That's the advantage of pulse wave Doppler. The disadvantage is that only low flow velocities can be measured with this. High flows, we need to go for continuous wave Doppler.
So similarly, the next question is asked to how to record velocity flow across valves. So first of all, it is very important to know, first we have to use pulse wave Doppler, and according to which valve we want to investigate, we have to accordingly select the view, because we have to align the view exactly parallel to the flow across that particular valve, because the angle of incidence has to be less than 20 degrees of the flow through that valve. So accordingly, first we have to select the view in which we can align the Doppler exactly almost parallel to the blood flow through the valve, and then using it, first we can use pulse wave Doppler to find the velocity across the valve. If it is a turbulent flow, such as a stenotic or regurgitant, then we cannot use pulse wave Doppler since it will lead to aliasing. So we have to then shift over to continuous wave Doppler and measure the velocity through that particular valve.
Yeah. I would short say that if it is stenotic lesion, go for continuous wave Doppler. If you are looking at the diastolic function at the mitral valve, you have to go for pulse wave Doppler. Is that okay with you, Dr. Gegal?
Yes, sir.
Do you want to add anything else to that?
For higher velocities, we have to use this continuous wave, and for the lower velocities, we have to use the pulse wave Doppler.
Right. So in essence, it is for stenotic lesions, go for continuous wave straight away. Can I say that?
Yes, sir. Yes, sir.
There are several questions. Can you go through that, Dr. Sushmit?
Yes, sir. So next question is zoom versus focus. How to decide? So I think we have to use both the controls. It is not selecting one over the other. So focus is anyway important because we have to focus on the area which we want to see best, because automatically it will lie in the focal area of the ultrasound beam, and the lateral resolution will be the best in that area. So the focus dial has to be used to at the area which we want to see best, and then we can use zoom based on whether we want to uh, enlarge the particular part or anything else. Dr. Gegal, you would like to add in that zoom versus focus?
Yes, we have to use both wherever necessary. You can zoom the area where you want the planimetry measurements, and then use the focus where at the center of the screen, or wherever you want to do that focus, that region of interest, you can put the focus also, because that will improve your lateral resolution at that point. After doing zoom, you can do focus at that particular area of interest.
Because as we already discussed that using zoom will enlarge the area and the pixel size, but it may not increase the resolution.
Yes, it will not decrease the resolution.
So now we'll take the next question. This is Dr. Venkatesa Kumar is requesting to please repeat how to increase the Nyquist limit. It was already discussed in the class. I think we can just repeat it once more. And similarly, there's another question almost similar to that. The what is the pulse repetition frequency? I think it can be covered in this same repeat of Nyquist limit.
Gegal, you are muted. Please unmute and speak.
Yes, sir. Yes. So, just we have seen that in this figure A, you can see if the frequency is lesser than the Nyquist limit, there is no aliasing. But if your frequency is more than the Nyquist limit, there will be aliasing, and your velocities and direction of flow cannot be determined. But we can increase the Nyquist limit by either sending the decreased frequency transmitted waves, so by using the decreased frequency probes, or keep the sample volume nearest to the probe. Your area of interest should be nearest to the probe so that it should come in the near field. Or you can use the baseline, you can shift it downwards, or you can shift your baseline, and also you can decrease the sector size and the depth. So this is how you can increase the Nyquist limit so that you don't have the aliasing.
Yeah. Similarly, the next question is almost similar. How to adjust the scale when aliasing happens? So in pulse wave Doppler, we cannot change much because aliasing will always happen when the frequency is beyond the Nyquist limit. So in case of aliasing in pulse wave Doppler, we can only go in the direction of interest as much as it allows. Beyond that, we cannot adjust the scale.
Yes, but in
The next question, yeah,
but
yeah,
in continuous wave Doppler, yes, we can change this scale and the
yes,
baseline.
yes, yeah. But it was the question was about aliasing, so that usually happens only in pulse wave Doppler.
Yes, yes.
The
Okay, okay.
next question, yeah, yeah. The next question is which is the ideal? What is the ideal frequency for color Doppler for quantifying regurgitant and stenotic flows? So in case of turbulent flow, the ideal frequency in case of color Doppler is around 50 to 60 centimeters per second.
Yes, I agree.
And in case
Gegal, do you want
you
to
are
add quickly anything you want to say?
I'm not able to get the question. Sorry. Wait.
Question is, what should be the color Doppler Nyquist limit adjusted on the machine to get a proper interpretation of the color Doppler signal?
Uh,
Is
uh,
that
I-
right?
it should be 50
Sushmit,
to 60. 50 to 60. It should.
centimeters per second. Yeah.
Yeah, centimeters.
if
Go
it
for
is
the
a
next.
regurgitant, yes, sir. And in case it is you are thinking that it's a smaller ASD jet or a pulmonary
Or the
venous
cord.
flow, then we have to decrease the color Doppler scale to less around 20 30. But in case of regurgitant or turbulent flows, we have to keep it around 50 to 60.
Yeah.
The next question, any way to confirm the angle of insummation only parallel in color Doppler and perpendicular in B mode? So there is no way to confirm this paradox is always present. We cannot use the in most of the views we cannot use the same view for 2D as well as Doppler, because in 2D mode we require the area of interest to be perpendicular to the ultrasound beam, whereas in case of Doppler we require it to be parallel to the flow which we are studying. So this paradox always exists. There is no way to confirm. We have to select the view according to what we want to exactly study. The next question is about gain. It has been already discussed when to use time gain and lateral gain compensation. I think Dr. Gegal can just repeat on that, when the time gain and lateral gain can be used.
So time gain compensation you can use for the far field structures. So you can use the step ladder pattern or choose the area of interest and adjust your time gain compensation accordingly for the mainly for the vertical things for the far field zone. Whereas the lateral gain compensation, you can selectively amplify across the width of the image display. it is mainly for your endocardial borders. It is mainly for visualizing the lateral walls.
Yes. So this
You
question, I
add?
think there was another question on lateral gain compensation. So this covers that also. The next question is when we should use continuous wave and pulse wave Doppler. So
This has already been discussed as pulse wave for the lower velocities and continuous wave for the higher velocities flows.
there is another question on how to adjust frame rate. Dr. Gegal, you can just, I think, discuss on frame rate, how to adjust it.
Yeah, we can decrease the depth to increase the frame rate. Ideally, it should be more than 20. You can see on the screen, your region of interest should be in the near field. So you will have the increased frame rate, which should ideally be more than 20. So your region of interest ideally should be, you can use zoom, you can decrease the depth to increase the frame rate.
Yeah.
Anything else
So
to add?
frame rate is actually synonymous with temporal resolution. So we have to adjust the depth and the sector accordingly. The sector depth has to be reduced so that we can see just the area of interest, and also the sector angle can be reduced. This will all increase the frame rate and improve the temporal resolution, as already discussed. There is a question on what is pressure GDT. Sir, any idea? Pressure GDT.
What is that?
So what is pressure GDT?
Pressure?
Has not been
I think this is
pressure
pressure
GDT
gradient.
gradient.
Yeah.
Pressure gradient.
Yes, sir.
Pressure gradient is the difference between the pressure on either side of the stenotic lesion. Usually we use the Bernoulli's principle, modified Bernoulli's principle to get the pressure gradient. If it is aortic stenosis or mitral stenosis or any other place where you want to measure the gradient, for example, after repair of mitral valve, if you want to know the pressure difference on either side of the valve, we need the pressure gradient. It's based on the Bernoulli's principle, which says that delta P is equal to 4V square. V is the velocity. This is the simplified Bernoulli's principle. Delta P is the pressure gradient is equal to 4V square. Gegal, you want to modify that reply?
No, sir. That is what 4V square is. The pressure gradient is 4V square, where V is the velocity. It can be V2 minus V1, that is the second
Yeah.
chamber minus first chamber. And if the velocity of the first chamber is less than 1 meter per second, you can directly go to the modified Bernoulli's equation, that is 4V square. And that is how you can calculate the pressure gradient across the valve.
Yes.
Finally,
Next
we come to
question.
the last question. The last question is that up to what velocity we can actually use pulse wave Doppler, and does it change with the probe frequency? So, Dr.
Up to
Gegal, you can just,
we can use pulse
yeah.
wave Doppler. I think it should be less than 4 meter per second. And does it change with the probe frequency?
It is 1.2 to 1.5 meter per second.
Yes.
Less than
Less than
1.4.
less than 2, yes. It is less than 2 meter per second. And does it change with the probe frequency? I think it will not change with the probe frequency.
Correct.
Yeah, and we'll automatically come to know whether aliasing is occurring because there will be wraparound in the pulse wave Doppler, spectral Doppler. So then immediately we can shift over to continuous wave Doppler once we know that aliasing is happening at that frequency, at that velocity. There is another question which has just come. At what position inside the esophagus or transgastric is the best for aligning waves parallel to the Doppler imaging? So it it will depend on which structure we want to is the structure of interest, because some structures can be aligned in the Doppler in the mid-esophageal views, whereas for say flow through the aortic valve, we have to go deep transgastric and then we can align it with the flow through the aortic valve. Whereas if we want to see the flow through the mitral valve, then mid-esophageal four-chamber or the mid-esophageal views are the best views for aligning. So it depends on the structure of interest rather than the position. The next is about velocity time integral. How do we interpret velocity time integral?
VTI is velocity time integral. It is at this velocity how much distance you have covered. So it is calculated by tracing the envelope of the Doppler spectrum of the, for example, LVOT systolic flow. So you will know how much distance the blood flow has covered in that time. So that is velocity time integral. You can just trace the envelope and you will get the VTI.
Yeah.
Next
If you
question.
want to know the flow across an orifice, you need to know the velocity and the cross-sectional area. And because the blood is not exactly like water, there is a difference in the velocity of the blood which is in the center of the vessel as compared to the periphery. So to get all the velocities together, it is to have to integrate with the time and you get the velocity time integral. It's an automatic function which is exhibited by the monitor. Once you trace the spectral Doppler, either it's pulse wave or continuous wave, the VTI is once you trace the Doppler, spectral Doppler tracing, you will automatically get the VTI recorded on by the machine. So we don't have to do any specific measure to do that. As long as you trace it accurately, we'll get a reasonable estimation of the VTI, which is used to measure the output, especially the stroke volume across the LVOT. Is that, do you want to add anything to that, Gegal, regarding VTI?
No, sir, that's it. Yes.
Now go to the next
Yes, sir.
question, Sushmit.
Yes, sir. The next question is which echo window is used for which valve in color Doppler study? So, as already discussed, most commonly studied valves are mitral and aortic. So, as far as PE is concerned, for mitral valve, the midesophageal four-chamber view or the midesophageal LV long axis view can be used as far as we can correctly align the Doppler with the flow. For aortic valve, we have to use the deep transgastric or the transgastric long axis view. And finally, for tricuspid valve, we can use either midesophageal four chamber or modified bicable view to align the Doppler along the tricuspid valve.
Right. I agree with that.
And finally, coming to the last question is what is modified Bernoulli and how do you know when to use? As Sir has already discussed, modified Bernoulli is used to measure the pressure gradient, which is equal to 4 velocity square. These algorithms are already there in the machine. So when we trace the Doppler velocity time in the curve, we immediately get the pressure gradient when the velocity is calculated.
Yeah. Delta P is equal to 4V square. Just remember that. Delta P is equal to 4V square. That is the Bernoulli equation, which is commonly used to determine the pressure gradients. Thank you.
That is the last question, sir.
So any comments from the experts who are in the meeting? Dr. Jaswinder is there. Jaswinder, you want to say anything?
Good morning, sir.
Good morning.
It was very good presentation.
Yes.
And sir, I would like to add that if possible, more than one view should be interpreted before commenting to the that particular structure.
Absolutely. Very vital point. Thank you so much.
Okay, sir.
I think Sushmit, final comments and close the session. After that, there'll be a couple of brief videos.
Yes, sir.
Muradhar?
Good morning.
Yes, Sanjeevani, I didn't notice you. Please carry on.
Nice to see Gegal after many months. Gegal, it was a beautiful and simple, calm, quiet presentation, and a difficult topic, of course. All these basic topics are very difficult. A beautiful narration of Nyquist limit. Only one thing I would like to ask you, which is the beneficial effect of Nyquist limit? In which scenario? I mean, when do we reduce it and take help of it?
Please unmute yourself.
Yes, ma'am. Can you repeat the question, ma'am? When do we reduce?
Nyquist limit is, bad, and we have to, do many things to decrease the aliasing, but in which some places we have to reduce it, reduce the velocity, color velocity, and then take the help of that to measure some measurements. So anyway, I will just let you know. This is in
One
pulmonary
is,
vein.
ma'am,
Hmm.
pulmonary vein and
Yes. Yeah, you
small
did tell us. You
ASD.
did tell us, Sushmit. Yes.
Yeah, small
Small
ASD might
velocity.
be
Yes.
missed.
Otherwise, you
And
wouldn't.
even for pizza, we have to reduce it and get the
Yes,
Nyquist
yes,
limit
yes.
when while
Yes,
calculating pizza.
yes. You
Even
wouldn't
for
otherwise.
coronary
Pizza
flows,
also. Yes, pizza also.
coronary velocity flows also we can reduce
Correct,
it.
Yes,
correct,
yes.
correct. So these are a few beneficial effects of reducing Nyquist limit. And another question was Dr. S.K. Deshpande about focus and what did he
Zoom,
ask?
ma'am. Zoom.
Zoom, correct. So
Yeah.
one has to first focus, for example, aortic valve area, which is the ideal way of measuring aortic valve area in transesophageal. They approve TEE better than TTE. So you focus there first, and then you zoom that area so that the resolution is good by focusing, and by zooming the error of measurement is less. So you focus and zoom. Another area is LVOT. You focus and zoom. You have to zoom before measuring LVOT diameter for calculating aortic valve area by your continuity equation. So
Continuity.
these are very basic things, but we forget these while doing examination. So one has to focus and then zoom.
Can I say that zoom is something like a lens where magnifying lens, you want to see at some object which is small, you're just magnifying it and seeing it. Can I compare it to that, Dr. Sanjeevani?
Gegal said that zoom doesn't reduce the resolution, isn't it? It
No,
was.
it doesn't reduce the resolution, but it
No,
increases the
but
size
it
of the
must be
picture.
like magnifying.
It
Well,
increases the size of the image
correct.
without reducing the resolution. That is the.
It's like a good phone where the resolution does not decrease, but you magnifies.
iPhone. Okay.
That's right.
Thank you, ma'am. So it was a very
One
informative
more
and
thing, Sushmit.
yes,
One more.
yes, ma'am.
When Gegal, when would you like to reduce the gain to maximum to get something to diagnose? Reduce. Don't see anything, but you measure. Uh,
Reduce the gain to
reduce.
2D gain, no?
Huh?
2D gain.
2D gain.
Uh, to see
Then
something.
only you diagnose it. Then only you diagnose it if it comes positive. I mean, if the measurement is, that is in pericardial thickening, calcification. You see
Okay.
constrictive pericarditis. They nowadays with lot of oncology and echo coming up, because of these toxic these drugs used in oncology, they are causing calcification of pericardium. Though the pericardium tuberculosis is decreasing, but this is coming up. So here you have to reduce, and even then, if you see there is thickening, then it is calcification of pericardium. That is
Okay.
one way of diagnosing it.
Okay, thank you, ma'am.
Thank you. Thank you.
Thank you so much. Thank you, Dr. Sushmit Kamat and Dr. Gegal for that excellent session. Thank you, Dr. Jaswinder and Dr. Sanjeevani for joining us and giving your input. And I would like to thank all the faculty and other delegates who are present in this meeting. And I would like to thank you. And before we conclude, I think there must be a couple of videos. One is the announcement of the IACTA TEE in August. Please join us. And the other one is about Global University of Cardiac Sciences. Can you play those two videos quickly?
Mulita sir, I believe that it was visible, sir. So I'm playing the.
Yeah. One more video.
Yes, sir. I'm.
Thank you so much and have a great Sunday. I would like to thank both Lirnit and Rajiv for the logistic arrangements. Thank you so much.
Thank you
I'm
so much,
looking
sir.
forward to seeing you next Sunday for another topic. Thank you.
Thank you so much, everyone, for giving us this opportunity to host this session. So now, with all your permission, I'm closing the session over here. Thank you, sir.
Thank you.
Thank you, sir.